Hello, my name is Jessica Wilson. Today is August 26th, and I'm going to be performing a head-to-toe throughout the exam. I am going to be touching you. Is that okay?
Yes.
I'm going to start by, throughout the exam, inspecting her skin, looking at the color, the moisture, the texture, the turgor, and the temperature, looking for any signs of edema, scarring, bruises, lesions, or nevi. I'm going to move to her head first, inspecting it, making sure that it's normocephalic, symmetric, and midline. I'm going to inspect and palpate her scalp, feeling the hair's texture, color, feeling for any depressions, masses, lesions, tenderness, or indentations, which I feel none. I'm then going to palpate the temporal arteries, feeling for any tenderness, which I'm noting none. I'm going to move on to the lymph nodes, feeling the pre-auricular, the post-auricular, occipital, the tonsillar, submandibular, submental, anterior cervical, posterior cervical, and supraclavicular. From here, I'm going to come up and assess for TMJ. If you will just kind of open and shut your mouth, move side to side, feeling for any subluxation, tenderness. And then I'm also going to here test cranial nerve 5, the masseter muscle, if you'll clench your jaw, it's intact. And then I'm going to assess the sensory aspect of cranial nerve 5. If you'll close your eyes and tell me where you feel.
Forehead, nose, cheek, chin.
Perfect. And then I'm going to have you open your eyes and look at me, testing cranial nerve 7. If you will smile, frown, puff out your lips, puff out your cheeks, raise your eyebrows. Cranial nerve 7 is intact. From here, I'm going to move to the ears, inspecting the outer ears bilaterally, feeling and palpating the pinna and the tragus for any lesions, masses, or tenderness, which note none. I'm going to inspect the auditory canal bilaterally, noting any abnormalities, looking at for that clear pearly gray tympanic membrane. Perfect. And then I'm going to test cranial nerve 8. If you will occlude your left ear and repeat after me. 3, 2, 1.
3, 2, 1.
And then occlude the other ear. 1, 2, 3.
1, 2, 3.
Perfect. And then I'm going to perform the Weber test for lateralization of sound. If you'll tell me if you hear this in one or both ears.
Both.
And then the Rhine test. If you'll tell me when you stop hearing this.
Now. 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 Now.
Okay, air conduction is greater than bone conduction bilaterally, and cranial nerve 8 is intact. I'm then going to move to the eyes. First, inspecting the eyebrows, the eyelashes, and the palpebral fissures, looking at the conjunctiva, the sclera, looking at the color, the moisture, looking for any lesions or discharge, which I see none. I'm going to start by testing the gross visual acuity. Cranial nerve 2, if you will, occlude one eye and read the lowest line that you can.
D-E-F-P-O-T-E-C.
And the other eye.
D-E-F-P-O-T-E-C.
Okay. Patient has 20/20 bilaterally without corrective lenses. And if you will, tell me what number I'm holding up.
2, 1.
Perfect. Vision is intact both centrally and peripherally. I'm now going to assess the eyes, if you will, looking for pupillary response. If you look at my nose, pupils are equal, round, and reactive to light, both directly and consensually. And then testing for accommodation and convergence. If you look at my pen light and follow it in, then focus on it, and then look at both of my shoulders. Accommodation and convergence is also intact. I'm then going to have you follow my finger. Okay, cranial nerves 3, 4, and 6 are intact. And then I'm going to look at the internal eye structures, testing the red reflex, making sure there's no signs of abnormalities. Perfect. Now I'm going to move to the nose, looking at the position, making sure it's midline and symmetric, which it is. I'm going to have you occlude both nostrils and breathe in and out. And what do you smell?
Cookies.
Cranial nerve 1 is intact, and their nasal patency is noted. Also going to palpate the frontal and maxillary sinuses, which I feel no tenderness there. I'm then going to move to the mouth. I'm first starting by inspecting the mouth. If you'll open up for me wide, I'm looking at the mouth, the teeth, the tongue, under the tongue, the buccal mucosa, the soft palate, the salivary ducts, the tonsils. If you'll say ah, cranial nerve 9 and 10 are intact. The soft palate and the uvula rise with phonation. And if you will stick out your tongue for me, cranial nerve 12 is intact. The tongue is midline without fasciculations. I'm then going to move to the neck aspect of the exam, palpating the trachea, making sure it's midline, which it is, and then have you swallow, which is palpating the thyroid gland. I don't note any nodules or tenderness there. I'm going to palpate the carotid arteries, and then I'm going to auscultate the carotid arteries with the bell of my stethoscope. Take a deep breath in and hold it. Okay. Deep breath in and hold it. Okay. Then I'm going to move to the chest portion of the exam. I'm going to start with the posterior chest, looking for any obvious signs of deformity, looking at the symmetry of it. I'm going to start by assessing for any respiratory distress, cyanosis, tachypnea, nasal flaring, retracting, tripod positioning, anything like that, and I don't see any. I'm going to check for chest symmetry, if you'll take a deep breath in, which it is, and then I'm going to check tactile firmness if you'll say 99 when you feel my hands.
99, 99, 99, 99, 99.
Perfect. And then I'm going to percuss in the lung space, intercostal spaces. Ensuring to go down and get in the lateral lung fields and the lower lung fields as well. And then I'm going to auscultate with the diaphragm of my stethoscope, starting above the scapula, moving in a stair-step manner, going back and forth, and ensuring to get the lower lung fields and the lateral lung fields as well. And then from here, I'm going to check for agophony. If you will, say E when you feel my stethoscope.
E, 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 E.
And I would continue that through the lower and lateral lung fields. And then I'm going to check for bronchophony. If you will, say 99.
99, 99, 99, 99.
And I would also continue that through the lower and lateral lung fields as well. And then for whisper pectorilically, if you'll whisper 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
And I would also continue that through the lower and lateral lung fields as well. I'm then going to move to the anterior chest wall. Again, inspecting for any obvious signs of deformity, making sure the chest is symmetric. I'm going to palpate for chest wall expansion if you will take a deep breath in. Perfect. And then tactile firmness if you'll say 99 when you feel me touch.
99, 99, 99, 99, 99.
Okay, and then I'm going to auscultate with my diaphragm. I'm just going to listen to lung fields in the intercostal spaces, moving back and forth, ensuring to get the lower lung fields and the lateral anterior lung fields as well. From here, I'm going to move to the cardiac exam. I'm going to start by listening to the aorta or the heart valves. The first valve I'm going to listen to is the aortic. It is second intercostal space, right sternal border. Pulmonic, second intercostal space, left sternal border. Herbs, third intercostal space, left sternal border. Tricuspid, fourth intercostal space, left sternal border. And the mitral is fifth intercostal space, mid-clavicular line. This is also the point of maximal impulse and where I would auscultate here for a full minute, noting the rate and rhythm. I'm then going to listen to all of those again with the bell of my diaphragm. So I've got the aortic, pulmonic, herbs, tricuspid, and the mitral. From here, I'm going to have the patient lie back, noting at a 30 to 45 degree angle if there's any JVD distension or pulsation, which I see none. I'm going to inspect, looking for any heaves or lifts, and then I'm going to palpate, feeling for any thrills in the cardiac valve areas. I'm then going to repeat my stethoscope assessment of cardiac, doing the aortic, pulmonic, herbs, tricuspid, and mitral with my diaphragm, and then aortic, pulmonic, herbs, tricuspid, and mitral with the bell. I'm then going to move to the abdominal aspect of the exam. Is it okay if I raise your shirt?
Mm-hmm.
Okay, I'm going to note the symmetry and contour of the abdomen, which everything's symmetric, contour is normal. I'm going to start by auscultating with my bell, feeling for or listening for any bruits of the abdominal aorta, the renal arteries, the iliac arteries, and the femoral arteries. I'm then going to move over to the diaphragm, listening to vowel sounds, starting in the right lower quadrant. I'm then going to percuss, listening for any tympany dullness or flatness. I'm then going to do palpation, feeling for any masses or tenderness. And I'm going to palpate the liver and the spleen. I'm then going to have the patient sit up for me, and then I'm going to test for CVA tenderness, which none is noted. I'm then going to move to the musculoskeletal aspect of the exam. I'm going to start with the upper extremities. I'm going to inspect and palpate the hands, the wrists, the elbows, and the shoulders, feeling for any redness, swelling, tenderness, crepitus, nodules, symmetry, and deformities. I'm going to palpate the radial pulse and feel for look for capillary refill, which is normal. We're going to do the range of motion of the fingers. If you'll follow me: flexion, extension, hyperextension, adduction, abduction, and thumb opposition. For wrist, flexion, extension, hyperextension, radial deviation, ulnar deviation, and rotation. For your elbows, flexion, extension, hyperextension. For your shoulders, flexion, extension, hyperextension, inversion, eversion, adduction, abduction, and then circumduction. We're going to go ahead and test the strength of all those areas. If you'll squeeze my hands, perfect, and then pull against me, and push against me, then push against me, and pull against me. Strength is 5 out of 5 for the hands, biceps and triceps, and the shoulders. I'm then going to come behind you and have you shrug against my resistance. Okay, cranial nerve 11 is intact. From here, we're going to test some cerebellar coordination, if you will. Do serial finger opposition, okay, and then do the hand flop, and then touch your finger to your nose and repeat it and follow my finger. Perfect. I'm going to have you close your eyes, and I'm going to test a light sensation of your upper and lower extremities. Just tell me where you feel.
Arm, knee, leg, foot.
Perfect. And then I'm going to test for vibratory sensation of both on your ulnar prominence. Can you feel?
Yep.
And then the medial malleolus.
Yep.
Okay, and then I'm going to test for graphesthesia and sterignosis. If you will keep your eyes closed, open your hands, tell me what you feel.
Coin.
And then what letter?
C.
Perfect, I'll take that from you. And then from here, I'm going to move to your deep tendon reflexes with your arms. I'm going to do the brachioradialis, tricep, bicep. Come to this side. Brachioradialis, tricep, bicep. Then I'm going to do your knees, patellar, and then Achilles, and then we'll test your Babinski. Perfect. Then we'll move to your lower extremities. I'm looking at your toes, palpating your ankles, knees, and your hips. Doing your cap refill of your lower extremities, feeling your dorsalis pedis and your posterior tibialis pulses. They are intact. We're going to do range of motion of your toes, if you'll do with what my hands are. So flex, extend, hyperextend, abduct, adduct. And then for your ankles, if you'll flex, extend, inversion, eversion, and rotation. Then for your knees, flex. Well, we'll do your knees whenever you stand up. But if we're gonna go ahead and test the strength of your feet, if you'll plantar flex down, dorsiflex up, then your knees pull against me, push against me. Then for your hips, pull against me and push against me. All right, we're gonna go ahead and stand up. We'll do the range of motion of your knees. If you'll flex, extend, hyperextend, flex, extend, hyperextend. For your hip, we're gonna flex, extend, hyperextend, inversion, eversion, adduction, abduction, and circumduction. And then we're gonna flex, extend, hyperextend, internal rotation, external rotation, adduction, abduction, and circumduction. From here, you're gonna kind of turn facing away from the camera. I'm gonna have you bend over and check your spine, feeling for any signs of scoliosis, checking the curvature, making sure there's no signs of redness or deformity. From here, we'll do spinal range of motion. You're already flexed, so we'll extend up, hyperextend back, lateral flexion, and then rotation. Do your cervical spine. So we'll flex down, extend, hyperextend, lateral flexion, and then rotation. Perfect. I'm gonna have you walk away from me normally and walk back to me heel to toe. And then as you get here, I'll check your Romberg. If you'll just stand still with your eyes closed, Romberg is intact. And then if you'll hop on one foot and then hop on the other foot, that concludes our assessment.